First of all, my greetings and Mubarak for the Holy Ramadan. And before I start, let's wish and pray Almighty that the crisis which are going through, let it be over shortly. And most of the people who are suffering from the COVID-19, we wish and pray for their speedy recovery. And inshallah, we will win over the current crisis over a period of short time. With this, we have a very good panel of experts who is who in the diabetology and endocrinology. They are going to discuss some various aspects of diabetes and COVID-19. I will start with my colleague and dear friend of mine, Professor Abdul Hamid Zargar, whom I know for more than 40 years. He is running a Center for Diabetes and Endocrine Care at Srinagar, and he has been a former member Medical Council of India. He has been a past president Endocrine Society of India. He is on the member institute body AIMS New Delhi. He has been chairman the Department of Endocrinology, director and ex officio secretary to the government, Sher Kashmir Institute of Medical Sciences, Srinagar. He has innumerable original article in various national and international journals, and we are proud that Abdul Hamid Zargar, who created the Department of Endocrinology, and you can see some of the best publications from that area. Now, thank you. Dr. Sunil Ambulkar, he is a renowned endocrinology and working in the Institute of Clinical Endocrinology and Diabetes Care Unit, Nagpur. He has been he is associate professor and head of Department of Endocrinology, GMC and SSH, Nagpur. Organizing chairman, co-chairman, SECON 2019. He has a clinical fellowship in USA in 2003 and UK 2010. And he has been principal investigator phase 2 and phase 3 clinical trials in diabetes, osteoporosis, and dyslipidemia. He has many articles in national and international journals. Now, over to Dr. Anil Kumar Virmani. He is a fellow of Indian College of Physicians, Indian Association of Clinical Medicine, American College of Physicians, fellow Diabetes India. He is a consultant physician and cardiodiabetologist, Jamshedpur, Jharkhand. We know the upcoming specialty, the cardiodiabetologist, is very important in our country. He has been holding various posts: chairman, Indian Association of Clinical Medicine, Jharkhand chapter, vice president, Clinical Cardiodiabetes Society of India, faculty, School of Diabetes, Diabetes India. He has been chairman, scientific committee, API, CSI. He is a founder member of Clinical Cardio-Diabetes Society of India, and he is speaker at national international conferences. To set the context rolling, I'll just brief you about COVID and diabetes, and I'll show you some slides, just 3 or 4 slides, just to brief you about the COVID and diabetes. And after that, we will start having discussion with the panelists regarding some aspects of diabetes and COVID-19. Now, to start with, this is just introductory slide. Corona and diabetes guidelines in current scenario. Now, brief introduction about what is coronavirus. The coronavirus, the 2019 novel coronavirus infection, is a respiratory infection caused by a virus. It's called SARS-CoV-2 is the name of the virus, and COVID-19 is the disease it causes, and it belongs to the same families of SARS and MERS, the Middle East respiratory syndrome and the severe acute respiratory syndrome. Mainly causes respiratory symptoms including fever, cough, and shortness of breath, and can lead to pneumonia in lungs. It was first identified December 19 in Wuhan, China, and has spread globally. But what we came to know right from the September, before December also, there's one strain which was doing rounds in China, that's type A. When it mutated, it gone into type B, and we started showing which was more serious, than showing the results from December 2019. Though believed to have originated from an animal host and is now spreading by human to human transmission, we still don't know because a lot of controversy regarding the origination of this particular virus. Currently, there is no vaccine available or antiviral treatment which has been proved to be beneficial. Clinical trials are underway and vaccine might be expected in coming years to come. I just want to tell you that the main two distinctive comorbid conditions which emerged from the COVID-19 patients were diabetes, cardiovascular disease, and chronic lung disease. You can see the lower bottom. But these were the main distinctive comorbid conditions which we found and which was basically responsible for the increased mortality. Now, coming to the various bodies or organizations, their position statement about the coronavirus and people with diabetes. I will start with the ACE guidelines. ACE is the American Association of Clinical Endocrinologists. They are just told, the recent studies have shown that of those hospitalized for severe disease, 22% to 26% reported living with diabetes, and diabetes and high sugar are associated with increased complication, respiratory failure, and mortality. Because people with diabetes may also have other comorbid conditions such as organ failure and CVD, it is imperative they follow specific precaution preventive guidelines from the Center of Disease Control and Prevention, the CDC, WHO, and other endocrinologists and healthcare workers. Coming to the IDF, they have the same thing to say that older people with diabetes, pre-existing medical condition, diabetes, heart disease appear to be more vulnerable. And when people with diabetes develop a viral infection, it can be harder to treat due to fluctuation in blood sugar level and possibly the presence of diabetes complication. There appear to be two main reasons. Firstly, the immune system is compromised, making it harder to fight the virus and likely leading to a longer recovery period. Secondly, the virus may thrive in an environment of elevated blood sugar. Coming to the American Diabetes Association, what they are told, the people with diabetes are not more likely to get than the general population. They are equally. People with diabetes do face a higher chance of experiencing serious complication, and people with diabetes are more likely to experience severe symptoms, and COVID-19 is proving to be more serious illness than flu and common cold, including people with diabetes, and the risks are similar. Now, last but not the least, this is my last slide. The RSSDI guidance for the people with diabetes or the healthcare professional. What they have come out, the problem people with diabetes face is primarily a problem of worse outcome, not greater chances of contracting the virus. People who already have diabetes-related health problems are likely to have a worse outcome if they contract COVID-19. In general, we don't know of any reason to think that COVID-19 will pose a difference in between type 1 and type 2. More important is that people with other diabetes vary in their age, complications, and people who already have diabetes-related health problems are likely to have worse outcomes. With this, we proceed on to asking some of the burning questions for our panelists. And I will start with Dr. Virmani. Dr. Virmani, you already heard some of the important information which I showed in my slides. And again, we had to re-emphasize and reiterate whether the patients with diabetes and hypertension are at increased risk of acquiring the COVID-19 infection or not? Over to you, Dr. Gurman.
Thank you, sir. I hope I am audible. Uh,
Yes, clearly.
First of all, let us be very clear when we are talking about a patient who is diabetic, whether he is having good glycemic control or a poor glycemic control. If he is having good glycemic control and if he is normotensive without any comorbidities, then the risk of contracting the COVID-2 infection is similar to any healthy person. That means they are not at increased risk. But those diabetics who are having poor glycemic control, uncontrolled blood pressure, they have an increased risk of infection, especially viral infections like influenza and secondary bacterial pneumonias, because of an impaired immune response, both in relation to cytokine profile as well as T cell and macrophage activation. In fact, they may also be associated with obesity, which is independent risk factor, or other comorbid conditions. But as I said, if the patient has having good glycemic control, then these diabetic patients are not at an increased risk.
Thank you, Dr. Romani. Again, coming to the second question, which is just basically in relation to the first question, you already have explained that diabetics have more chances of experiencing serious complication from COVID. Can you just tell me what kind of a serious complication the diabetics might experience if the sugars are not well controlled? And that is the main cause of increasing mortality in diabetes.
Right. Now, there is a bidirectional relationship between COVID infection and diabetes. The persons who are having diabetes, once they contract an infection, their chances of having serious pneumonias, there's a very high risk of having severe pneumonias, excessive uncontrolled inflammation response with release of tissue-related enzymes, and there is hypercoagulable state. On the other hand, the infection itself leads to a dysregulation of the glucose metabolism. In fact, it has been seen that mortality is 50% higher in those who are diabetic as compared to the non-diabetics. And this has been seen by the various amount of pro-inflammatory cytokines that rise. Now, in worldwide data, if you see, amongst the non-survivors, almost 20%, more than 20% people have hypertension and more than 10% people are diabetic. Here, I must also stress that the presence of uncontrolled hyperglycemia on admission in a positive patient even with no history of diabetes and an A1C of less than 6.5%, that is so-called stress hyperglycemia, they have been shown to have increased length of stay and increased mortality. And in fact, their prognosis is worse as compared to those with known diabetics. Now, we also know that both acute and chronic hyperglycemia can modify the AC2 expression. We also have evidence that the presence of AC2 cells in the beta cells, what can happen is virus can damage the beta cells directly, and all this has been supported by evidence that there is a very high prevalence of diabetic ketoacidosis in these patients, other patients who are diabetes or who have uncontrolled hyperglycemia at the onset, and the insulin requirements are much greater as compared to otherwise.
Excellent explanation, Dr. Virmani. Thanks. Now over to Dr. Ambulkar. Now, people often ask, how can you differentiate between the common cold, the flu, and the COVID virus infection? Can there any discriminatory symptoms or any other signs which can basically warn the patient that he is suffering from COVID and not the common cold or the flu? Dr. Ambulkar.
Yes, thank you, sir. Common cold is common. Common cold, the principal symptom is running of the nose. They have mild fever and mild cough. Whereas influenza is because of orthomyxovirus and it occurs in winter days. This is not the time we will get lot many cases of influenza, where the fever is of sudden onset, high grade, myalgias and headaches are common. As far as corona infections are concerned, they start with mild sneezing, sore throat, they have fever, they have also high grade fever, cough. Cough is of moderate to severe variety and it is non-productive. That's very important. 30% corona patient can have loose motions also. And of late, they have noted the symptom, a peculiar symptom of loss of taste and loss of smell sensations. In fact, 80% are asymptomatic or mildly symptomatic. 20% patients are symptomatic. Out of these, 15% are moderately to severe symptomatic and 5% are critically ill. Critically ill, I mean that they required ventilatory support. This is a pandemic time, so any fever, you should suspect a fever lasting for 7 days. And if it is accompanied by shortness of breath, you should suspect, given the history of contact with a typical history what you get of travel or contact with a person, you should suspect corona.
I think you're right. The shortness of breath is the most distinctive symptoms in patient with the COVID-19 infection. As a corollary to that questions, I again go back to Dr. Virmani. What kind of a advice you should give to a diabetic patients regarding some warning signs and symptoms that they should start worrying that they have to go to a doctor for confirming whether they have not acquired the COVID-19. And Dr. Ambulkar has given some idea. I want you to elaborate 1, 2, 3, 4, 5, 6, 7, 8. Okay, you have this thing, contact your doctor and test yourself. Dr. Virmani.
Okay, the warning, we all know that the typical presentations are fever, dry cough, and shortness of breath. However, there are certain warning signs when the patient should be very alert about. Now, this is, for example, there's a lot of difficulty in breathing and shortness of breath. In fact, the respiratory rate is very high, more than 24 per minute. Second is when they have persistent pain or pressure in the chest with palpitation, when the heart rate is usually more than 125 per minute. Third, when they're confused or there is inability to arouse them. And number 4, when they develop the lips or the fingers become blue, possibly because of severe hypoxemia. So these are the warning signals which can be taken as a severity of this infection.
Thank you. Very nicely explained. Now, again, over to Dr. Ambulkar. We already talked that a patient who is a type 1 diabetes may be a small child or adolescent as compared to type 2 diabetes who may be middle-aged or elderly. Are the risk factors between these two important groups or between two types of diabetes are different or they are on the same boat? Dr. Ambulkar.
Yes, what Dr. Virmani has said, if you put a pulse oximeter, you get a silent hypoxia. If the oxygen concentration is 94, it goes to 86 and patient is still not symptomatic. So that is the earliest sign of picking up complications in COVID infection. Having said that, type 1 diabetics will definitely have chance of getting into diabetic ketoacidosis. This is a viral infection. In fact, any kind of stress in a type 1 diabetic can push that patient into DKA. DKA will manifest with a loss of appetite, nausea, blood sugars are high, and if the patient tests in addition to blood sugar, urinary ketones, they will be high. He has to increase the insulin requirement. In mild cases, he might manage at home, but in moderate to severe, he has to take opinion of a physician. Type 2 diabetes, as I already been said, is associated with hypertension in either second or third patient, chronic kidney disease, chronic heart disease, other comorbidities, and these comorbidities add to diabetes so that these patients are more prone for complications.
Thank you. Now we are going to proceed for an important discussion, and I'm going to have Dr. Zerger with us, and it is my honor to ask Dr. Zerger that we discuss all the common features of COVID, what kind of risk factors they face. Now coming, Dr. Zerger, you have to tell us what kind of a management protocol, before we start with the management protocol of diabetes, you give us some information about the management of COVID-19 as a general. What are any drugs available? What are the prophylactic use of any drug? We can tell whether it is true in non-diabetics and diabetics. Over to you, sir.
Very important. You know that apart from general management that we always talk about, and diabetes management we talk about, which we can come a bit later.
Right.
Specifically, some of the drug therapies that, firstly, I must tell you, there have been no specific drugs that will specifically target this particular virus.
Agreed.
Now, there have been certain trials which have come to the fore in the last couple of months. One was some data initially published from Wuhan on hydroxychloroquine. This was a very little data on 260 patients, and it was split into two arms. The placebo arm would mean fundamentally the supportive care as we give in any critical situation, and whatever respiratory care we give in people who have a respiratory distress, in all those who do not have that. In one line, two things were observed in that study. One, that there was a quicker symptomatic relief with hydroxychloroquine. And there was a numerically better outcome from the ICU. But it was not strongly significant statistically. Now, what was the big issue is that here we have a disease where we have 85% people asymptomatic. Now, quantifying people and then doing a randomizing trial would be something that would actually give the answer. Depending on how randomly you pick up relatively asymptomatic patients, symptomatic patients, symptomatic but who otherwise are hemodynamically stable, symptomatic who have a genuine respiratory failure, this gave some inkling, and that is how these first thoughts came in. Then there was some data published in International Journal of Microbiology, I think earlier part of this month only, which again was a data about 250, 260 people. Again, saying that yes, it looks like people get a symptomatic relief, probably help us in reducing the load of the virus in the body. In fact, a paper published only 2 days back where, even ICMR has recommended that hydroxychloroquine can be given as a prophylaxis in healthcare workers. But there has been a huge debate on this thing. For how long you give this so-called chemoprophylaxis? Do we give till a person is on duty and this infection is on? So I think probably because of lack of huge data and lack of a clear drug that straightway knocks it out, people are trying this particular molecule. But I must give two caveats. One, that this only should be given by a person who has now acquired some expertise in handling COVID infections in the recent few weeks. Because what has been seen that many people have started randomly picking up this hydroxychloroquine from the market, and there were times when in small towns it became scant. It means that, particularly after Donald Trump asked to sell it to him. So many people seem to be taking it over the counter, and
stocks are getting exhausted.
Yes.
In this part of the world, we straightway start holding it, and so that sort of a thing should be prevented. Another aspect is that India is a unique country where DCGI has approved this molecule for treatment of diabetes. Hydroxychloroquine was approved for diabetes in 2014.
Great, yeah.
Particularly in people who are already on sulfonylurea and metformin, and if they need a third additional drug. So this is
it's better to discuss them later date. We'll concentrate on
gliptin, the way we are paglitazone. And a lot of people, I was really wondering that a lot of people must be on this drug. And first thing that this drug has been available from 1952-54, for chloroquine to hydroxychloroquine.
for rheumatoid arthritis.
rheumatology field on that,
Tele.
field on this. But I would really wonder, Subhash, if lots of people in our country are on this hydroxychloroquine. I would love to see what is the prevalence of COVID in them. For diabetes, I'm saying that even I have a dozen or so on treatment of sulfonylurea, metformin, and hydroxychloroquine. So I must say only the people who are well versed with it today. Again, the safety is reasonably good because, as I said, 70, 75 years, but you have to understand two important problems with this molecule. One causing maculopathy, the eye problem. And when we are talking about diabetes, there you need to be a little bit careful. And cardiac issues with QT interval,
Yes.
and making it sure that a random person does not give it, a person on his own does not start taking it. So if given under supervision, probably might have some role which will crystallize over the next couple of months. In fact, there was a meta-analysis also published. I think COVID is one of the fastest researched on thing on this globe ever. I think every continent and every country is busy with it. So I hope and pray within a month, the sooner than later, we at least solve the problem of hydroxychloroquine, to what extent it helps.
The final answer, the one line is a big question mark.
Big question mark. Yes.
Let the professional handle it.
Yeah, professional handle it. Right. And Dr. Zaggar, you were talking about some other drugs, the antiviral drugs, and what is your opinion? Are antiviral drugs are going to be helpful in the current scenario? Because I am reading a lot of papers of various drugs which are undergoing trial, which have been completed, but all are having very controversial outcome. Your opinion?
I'll tell you two things, Subhash. There was a lovely paper published, I think, 3 weeks back in Nature Medicine, which tried to look at the biology of this, at the structural analysis of this COVID-19. And many people in the pharma industry started looking at the molecules that they already have. You see, the ones that they already have, and whatever pharmacokinetic, pharmacodynamic, and drug host relationship they already know for their own diseases. Like, I'll name few drugs for which, they're already in the market for an indication 1, 2, 3. Now they know where their molecule hits a virus. Now they thought if there is a homology of that area in this COVID-19, could it be tried? Now, one of the well-conceived trials was, I'm sure all of you know it on, we have a solidarity trial, we have drugs that have been used for HIV trial, and one of the most well-conceived trials was remdesivir trial. This had been, in fact, this came out during Ebola infection, if you remember. And they said probably there is some, if you look at that homology of the structure on that Nature paper, they said that Ebola also has certain similarities. Would this act? I think yesterday only they said it didn't work.
It didn't work.
To tell.
Absolutely. Yes. Yesterday only. Then there was this ritonavir and lopinavir combination. They said it might be working on two different areas. Subhash, basic aim was that if they quickly find out it works, then they would not need to go to FDA for an approval, because it's not a new trial, because that safety and other things have already been proved in other infections. So everybody said, go with it, sort of closing the eyes also. We have a problem. We have a burning forest fire, if something would help. Now, in majority of those cases, while those two drugs were given, a huge mortality benefit was not seen. So what in that solidarity trial they have given, they have added interferon also to it, because to prevent that cytokine storm. Now, solidarity trial is going to take a while. But they are combining these two antivirals also, along with this interferon. And that is yet to, because this is a relatively better structured trial. And now there are no two, as I told you, when 80%, 85% people are asymptomatic, So quantifying the impact of any drug which might have a potential impact is a bit difficult. But then probably only trying on people who already have a life-threatening disease. Probably one of these permutations and combinations might be tried. But again, in a hospital setting, in an ICU setting, by people who have acquired some expertise in handling these people. Today, most of the treatment is supportive care and preventing a secondary infection that we otherwise also have been doing. Looking at, respiratory functions are maintained, cardiovascular. In fact, I was amazed today finding out they have started a dapagliflozin trial handling it, the fluid retention in the body, the heart failure reduction. Just today inaugurated somewhere. So, so everybody is, looking at the pathophysiology of the disease and the structural nuances of the virus and trying to find out what best can be done and quickly can be done. So, about the, really, all the continents, including us here, are busy in trying to find out a vaccine that would not qualify as a drug. But many do believe that probably that will be the only thing, that maybe even a multivalent drug vaccine would be something that would ultimately be helpful.
Maybe because
Can I make a quick comment, sir?
Yeah, please.
All over the globe.
Can I make a quick comment?
Yeah.
Intensivist in the Italy who has managed this COVID patient says, first week it is an infective disorder. In the second week it is an inflammatory disorder because of cytokine storm.
Absolutely.
And they have given methylprednisolone 80 milligram on first day, then 40 milligram daily for 7 days. The moment patient enters on the 7th day, where there is a characteristic shortness of breath increasing, maybe by pulse oximetry or symptomatic, they are given 7-day course of methylprednisolone. And what she says on ground level, the risk of getting that patient into ventilator or those who are on ventilator, coming out of ventilators are very high. So in the first week is an infective disorder, in second week it is an inflammatory disorder. So that's why the steroids and there's monoclonal antibodies and all those things might help. We really don't know, but this is what our experience was.
There's a big question mark because this trial has been a very short number. We still can't come out with a very...
Yes. This is short, but this is a ground level experience.
A lot of people will come out with their own real world data and that will keep on helping. But there's no limitation.
So I'll again ask you some important questions that we always talk about the medicine, prophylaxis, but diet plays an integral part in diabetes management, and particularly during this COVID era when they are in the lockdown period where they are not access to majority of the things they should eat. What the general guidelines you give to a diabetic patient during this COVID era lockdown? What particular kind of diet they should adhere to for making themselves sort of a safe against acquiring this infection, making the blood sugar under control?
A diabetic diet which they are taking, they should follow. They should follow the instructions of the dietitian. दाल चावल रोटी सब्जी तो बनती है साहब सबके यहाँ पे, और डायबिटिक में तो यही चाहिए. So they should follow this diet. Those patients who have a problem with eating, then they should have consultation in the hospital by a different kind of diet. But all said and done, a simple diabetic diet prescribed by a dietitian should help.
I think second important thing is that patients should be advised to be well hydrated. They should get plenty of fluids during this period because it's the summer season. And you have rightly said that during this period, the same diabetic diet advice should be followed, what they have been following earlier, but they should be emphasized because one thing is good that all the junk food shops are closed. That is one thing, a sort of a good thing for them.
It's a boon in disguise, sir.
Boon in disguise, and they're relying on all the homemade food, lot of fiber and everything.
One important point here is that in these times of social isolation and stress, there is a tendency for inappropriate eating. People tend to snack a lot. So that is very important. They should be told, you have small frequent meals, do not over snack, and have your nutritious diet. That is very important here.
Now over to again Dr. Virmani, that if the diabetes who are having hypertension as a comorbid condition, they are already taking many drugs including ACE and ARBs. There was a little bit controversy after the Lancet paper where they found that increase in the ACE2 expression because of these medicines. And later on, it was found that, and most of the leading organization has said you can continue with the drug. What is your opinion?
Absolutely. See, first of all, we must understand why this controversy erupted. We all know that the entry point of this virus is the AC2 receptors on the cell surfaces. And we also know that the RAS blockers upregulate the AC2 expression. So there are increase in the binding sites, and theoretically there's an increased odds of infection if we give RAS blockers. But when they looked at literature, they could not find any evidence of this. On the other hand, we also know that this virus can impair the AC2 angiotensin MAS receptor pathway. And if it impairs that pathway, it leads to an increase in the deleterious angiotensin 2, which can lead to further pulmonary damage. So it is very important that these RAS blockers can block it theoretically and prevent the angiotensin 2 damaging the pulmonary cells. Having said that, when we look at observational retrospective studies, majority of the studies have shown that there is no difference in mortality on those patients who are on RAS blockers compared to those who are not on RAS blockers. In fact, a recent study from Wuhan itself by Peng in more than 1,100 patients showed that there were 20% patients on RAS blockers and 80% who are not on RAS blockers. In fact, in those who are on RAS blockers, there was a decrease in mortality. Having said that, again, all the with the current level of evidence that we have, all the societies, whether it be the European Society of Cardiology, the American College of Cardiology, the American Heart Association, or the International Society of Hypertension, all have given a very clear-cut 4 guidelines. Number one, as per the current evidence, we should continue RAS blockers because of the benefit of these RAS blockers in these patients. Number 2, even though a benefit has been shown in one of the trials, they are not to be used as a prophylactic drugs in patients who are not on RAS blockers. Number 3, those who are COVID positive and have not been on RAS blockers, please do not initiate RAS blockers on them in these patients. And lastly, those patients who are already on RAS blockers and have moderate and severe, that is category B and category C COVID manifestations, then monitor the blood pressure and the renal function closely, and you may discontinue RAS blockers if clinically indicated. Now, this is very important. Now, this is as per the evidence that we have today. Tomorrow, we are already having 2 trials with losartan. These are randomized trials with losartan in inpatient and outpatients. So perhaps we may get more evidence whether to use these drugs as prophylactically or not.
Thank you. Now we are another 5 minutes before we take question answers from the audience, our viewers, and this another 5 minutes over to Dr. Zargar, which is going to tell us that diabetic patient during this era, if there are certain medication, are there any specific class of anti-diabetic drug which they should avoid it, which may be deleterious to them, and what is the role of exercise in improving body immunity during this, what do you call, the lockdown period? Over to Dr. Zargar, all yours.
Firstly, so long as treatment is concerned, as I said, in most of the people, including those who have diabetes who get this infection, majority will have an asymptomatic disease. So there's no point in disturbing their management protocol. They should stick to their therapy that has been advocated. They should stick to the diet and exercise schedule to whatever extent possible. People who are on SGLT2 inhibitors, because now summers are around, at least in our country, dehydration would be an issue, so they should be well hydrated. If anyone develops now diabetes, but probably first time initiating SGLT2, you would be at this time a little bit hesitant. Giving a relatively safer drug, an established drug, would be better, like some gliptins and metformin. Exactly like as Anil was saying, that if first time you have to use, you may not use an S inhibitor today. In a similar fashion, if you use an SGLT2 today, not maybe the right time. But in those people who belong to that upper 15%, all of them they may get symptomatic. They might get symptoms, but they will not get a life-threatening issue where they would need either hospitalization or intensive care. But that small segment in them who would need hospitalization, because mortality has been shown to be higher in them. That's what is the concern. 2.5 against 7.5 in diabetic is those who reach the ICU. Here a person would be elderly. Here a person would be someone who would already have a relatively uncontrolled diabetes otherwise. Here a person would be someone who has a comorbidity, and a guy usually above 65. Right? So here, from this time, the sick day guidelines would take over. You say you completely take care of sick day guidelines. He would need a day-to-day care and management because now he has reached a hospital. Now he's in ICU. He would need an MSI. He would need his diet mechanization within the hospital. And probably most of the people will survive. Even today it says that if 7.5 is the mortality, it means 90 plus person will still survive. So within a month, they'll get back to what they previously were well controlled on. Exercise component during this lockdown. We have a tendency, as Anil was telling about snacking. In a similar fashion, even I got a tendency of getting up at 9 o'clock, wake up in the morning at 7, have a cup of tea and go back again. I don't know why. So, but that tendency, you see, we need to simulate normality. I know we don't feel normal. We don't feel normal, but we have to create that normality. At least spend some time walking in the courtyard, walking in the room. Some anaerobic exercises. If space is an issue at times, we can't walk on the streets, we can't walk on the malls. But given whatever the limitations we have, rooms, places where we live, just, a brisk walk within the room, up and down the stairs, and an anaerobic exercise within the room, preferably. If there are few guys at home with a spouse, with a sibling, join, because now everybody is doing practically nothing. If somebody is studying, somebody is doing something, somebody is doing work from home, find out a common timetable where you get down and have some exercises. I say from today, and maybe it in the long run would end up in, as my friend Sunil was telling us, blessing in disguise that, as you were just now telling about, fast food is not being available and many people have started, in fact, losing weight. And some people called me and said, you won't believe it, sir. We have lost 3 kilos, we have lost 4 kilos. I said, more too. Now we realize what junk you were eating. So the junk is not available, we are losing weight.
Yeah, that's nice. That's nice.
Absolutely. A girl called me the other day, sir, you were every day telling me you lose 10 kilos, you'll give me a prize. I have lost already 6 kilos.
Very nice.
So I said, you don't qualify for half the prize. Make it 10, I'll give one. So, you have to think novel. You have to think different because depending on what space is available and what mechanism. And probably if many times, Subhash, I must tell you, in Indian subcontinent, we are very shy. Like walking in home, telling our ladies, in a place where, you are burqa-clad women, we have heavily closed men. But then, if you involve everybody, it would not appear crude. If everybody is doing the same thing for half an hour, and if you say your doctor said it is good during this period, I think it might also end up in creating some new habits with us. So we'll have to look at out of ways of doing these things. Diet and exercise probably.
We have a health app. Every smartphone has a health app. Ask the patient to walk for 6,000 steps, 4 kilometers a day. They can just check it out.
Yeah. In fact, there are a number of patients who have a treadmill in their house, but it is being used as a clothes hanger. And now I've told them, now remove the dust and start using it. This is the treadmill.
Here we'll
than done.
Yes.
I also downloaded many apps.
Right.
Was exhausted for a fortnight. Downloaded apps for my children. Paid for it.
Sir, take the questions, please. Now there are questions coming up.
Now, first of all, Thanks a lot to all the panelists for the wonderful discussion on all the aspects of diabetes and COVID. We have certain questions from the viewers and audience. We will take one by one, and I will direct to any of the panelists who can take the current questions. So there's first questions which I got it that yes, the some suggestion that any suggestion regarding the use of low molecular weight heparin in all the cases of symptomatic COVID infection. Anybody can take this question because this is a question regarding the treatment as one of the treatment modality whether low molecular weight heparin is of some use or not. Has anybody some idea about it?
There are no studies. In fact, there was only one retrospective study which used low molecular weight heparin in around 20 patients, and 20 patients did not get it. And they did find striking differences as far as the coagulation profile was concerned. And there was decrease in the fibrin degradation products and D-dimer. But this paper that was published was not peer-reviewed. And they have also suggested that perhaps a randomized controlled trial would give us the answer. But at the moment, it does seem reasonable in those patients who have a very high hypercoagulable state. Maybe this may be of some benefit in those patients with cytokine storm.
Good. The another question which I think I will answer. Are there more chances of recurrence COVID-19 after the recovery from a previous COVID illness? It is very well known that even if the patient gets recovered, the virus remains in the body for a pretty long time. The patient may even be asymptomatic. It is not the recurrence of from another strain. It is the basically reactivation of the same strain the patient had got from the initial infection, had recovered, though the virus still remains in the body and it might reactivate over a period of time and after some time. So we have to be very, very careful. We have to do multiple testing to see whether the patient remained COVID-19 negative for a long period of time. And there are not many cases being reported about the reactivation of the virus, which has been already in the lung. Then the third question is that there are specific precautions of type 2 diabetic patient who had got associated comorbid condition like chronic obstructive pulmonary disease and hypertension. Do they have to take some special precaution? Anybody from the panelists?
I'll take this one.
Yeah.
Now, police has asked a specific scenario where this particular population is particularly exposed to infection and the complications of this infection.
Okay.
The fellow has diabetes, the fellow has comorbidities, the fellow has lung problems. So one of the first things would be take care of his diabetes as well as what. Second, as you said in your inaugural slides, that ensure that your sugars are as close to normal as possible to prevent to whatever extent the proliferation of this virus. Third important thing is these are the people where, strict, so not only social distancing, but actual distancing should take place. You see, they need to be pretty careful for the next 2-3 months. And not only they need to be, their family members. Many times what happens, Dudwala comes home, son goes out. If a person is 65 and above and he has the sort of problems that I think that fellow should be almost in a relative shutdown for next a month to two. And because that is a selectively chosen population where mortality is very high, where hospitalization is very high, where pneumonias with total desaturation and the consequence of like adult respiratory distress syndrome is very high. So they need to be particularly careful. So need to be their home people.
Good. Another very good question. He's telling that we have 4 top clinicians from all top hotspot of the COVID-19. Delhi, Srinagar, and Nagpur. From the hotspot of the country. What is the ground reality of the COVID management in diabetes patients today in Delhi, Srinagar, Maharashtra, and Jharkhand is not different. It has to be same guidelines. I think anybody can take the current. I told you the various organizations guideline, the RSSDA guideline. What is the ground reality of COVID management in diabetic patient today? Are they facing any problem? Are they facing any supply of the insulin? Are they facing anything? Anybody can take the question.
I will tell you, Ash, I was myself thinking about this. Imagine now Jammu and Kashmir has now today crossed 500, and out of them 450 are from Kashmir.
Yes.
Now, if you look at these hotspots, now you look at Bombay, you have a tremendous influx of people from outside, from whole of India and from rest of the world. You look at Bombay, you have the same thing. And now you look at Srinagar. A big chunk of people from Kashmir do walk out of Kashmir during winter. Small timers go for selling the shawls, a little bit of a business. Middle class people go for a winter vacation. People like me for a month or two up and down. And lots of elderly people go to visit their children. Many in the Middle East and lots of them in Saudi Arabia, and the richer ones who have children settled in the UK and United States. And they start coming back in below in later part of Feb and March. So the pathogenesis in all the hotspots is almost same. Literally comes down to the same, that influx coming from Delhi, coming from Bangalore, from children, and a lot of people go for during winter months for Umrah purposes. Even I went a couple of years back in the month of Jan only. So because you're on a holiday, you're on a vacation, and they come along with this load of COVID from there. And a lot of people go to Iran. The Shia segment goes for Iran for this thing. So people from Iran, people from Saudi Arabia, people from rest of the country who had gone on a vacation are dropped in the last without realizing that what is happening, because we were not aware of the magnitude of the problem even in the first week of March. So I think that this basically means that this lockdown has to be as stiff as possible, I personally believe.
Great. So there's a very good question. The role of vitamin D3 in the transmembrane serine protease receptor overexpression. Any protection role of vitamin D3 during this COVID era? Anybody from the panelist has got any experience? I have seen many articles on the vitamin D3, and even some cardiologists are advocating vitamin D3 during this COVID era, but I don't think so there's any hard data to prove that vitamin D3 has any protection role in this during COVID. Yes, anybody?
I just like to, I agree with you 100%. There is no definitive data. But in patients who are deficient in vitamin D, they definitely should be given vitamin D to improve the immune responses.
Cellular immune response, yes.
There is an immune response. Huh? There's one more question. Any urgency of
influenza vaccination?
Yeah, influenza vaccination.
You see, there is no urgency as such, but I will take this question. There is no urgency as such, but it is recommended for those patients who are COPD, those patients who are CKD, those who are elderly diabetics. Yearly influenza vaccination is recommended. So this is not going to be definitely helpful for COVID patients, but for influenza patients, which is often in this time of the year.
There is a question which has been already answered by the Dr. Zarga, which is the most preferred oral hypoglycemic agent. Oral hypoglycemic agent, he has already told you very nicely, elaborately, all oral hypoglycemic drugs can be given safely, except regarding some precaution about the SGLT2 inhibitors. But the question is that whether we should start insulin during this period to be much more sure that to have a better glycemic control, the patient is not controlled. Is the insulin the preferred choice of treatment during this era? Dr. Zargar.
I must tell you, very simple and straight. If the person's diabetes is reasonably controlled, let us not fiddle with it. These are not the times to experiment. But if diabetes is not controlled and he gets motivated, that is, Subhash, many people, dilly-dallying, we'll do it, sir, next time. We had a Vazman this time, I had gone out, I missed the medicine for 4 days, I missed. So you see, sir, next time what would happen? Probably if they now call us, because now people so liberally, share their records on WhatsApp, phones, now web consultations have started everywhere. You should tell them if they are uncontrolled and if there is a person to educate them, then there is no inhibition in insulinization as such. Because, anything that helps in improving the glycemic control is welcome. But we should also understand, given the limitations of current times, given the limitations of lockdown, given the limitations of access to healthcare and hospitals, particularly in elderly people who do not have a support at home, the class that I alluded to earlier on, where we need to be a little bit more careful. You start insulin on them, they don't know how to give it, they make an error of judgment, they get hypoglycemia, they cannot afford a second party intervention or hospital care. In that class of people, we should go a bit slow.
Yes, now we have hardly 1 minute left, and a question, Dr. Sunil, somebody had asked that if the patient is well controlled on a combo of glimepiride and metformin, would you like to shift him to DPP-4 inhibitor? Are they having any better role during this COVID-19 pandemic?
No, it's not like that. If the patient is comfortable and glycated hemoglobin is 7 on metformin and glimepiride, he doesn't have any nausea, vomiting, any side effects of the drug, then I would not be fiddling with these many patients. Though the gliptin is a second drug of choice after metformin nowadays for different reasons, or not during this period. We'll continue with the drugs which he is taking, and glycated hemoglobin of less than 7 will be maintained throughout this period.
Thank you. I think another 1 minute, and just before I finish it, there's one question which has been discussed widely. What precautions you have to take during Ramadan, Dr. Zargar? It is specifically asked Dr. Zargar to give some tips 1, 2, 3, 4 during Ramadan managing diabetes.
One of the first things is that people need to be told that you have to stratify subjects for Ramadan. Again, people with comorbidities, people with significant heart failure, people with coronary artery disease, people with renal dysfunction, they need customized care. Most of the people who do not have comorbidities, who are on metformin, who are on any form of gliptin, they can continue their fast and their drugs. Among the sulfonylureas, glycoside has been found to be safer. Glimepiride has been found to be safe. But only a proportionate change needs to be done in the drugs. As I said, I'll crudely tell it. If somebody is taking 10 milligrams of, let us say, glipizide in the morning, or let's say 4 milligrams of glimepiride in the morning and 2 in the evening, probably the morning dose would be shifted to evening at the time of iftar, and evening dose should be halved. Half of that dose should be given at suhoor. Most of the patients in Indian subcontinent on insulin are on premixed 2 doses. Now, whatever dose we are giving in the morning should be translated into a full dose at the iftar time in the evening. And whatever dose we are giving in the evenings, that dose should be halved in the mornings. If there is one basal insulin that a person is taking, decreasing it by 25%, it can be given at its own time. So this strategy would hold true for most of the people. Now with newer insulins, hypoglycemias are lesser. So if anybody is on those newer insulins, then probably hypoglycemics would be lesser. But remember one thing. People tend to overeat during the month of Ramadan for scare of hypoglycemia. That again is not a good tendency. Number 2, doing a blood sugar is permitted. It does not break your fast. Create a mechanism where a person can do his blood sugar in the morning that will tell us whatever drug and diet he has taken at the time of pre-dawn meal is adequate, is not causing hyperglycemia. And preferably keep on doing a blood sugar every second day, late in the afternoon, maybe about 5 o'clock, 4 o'clock, to see that you are not heading into hypoglycemia. Educate all people about hypoglycemia, and if there is any hypoglycemia, break the fast. People should hydrate themselves well during the non-fasting hours, because this time in the subcontinent, fasting is from 14 to 16 hours. And in many parts of the country, temperature is very high, 40 plus. So there is a chance of dehydration. People, again, who are on SGLT2s, take it in the evenings, hydrate themselves well. The morning food usually should be more complex so that it gets absorbed over a period of time, and enough of fluid should be taken at that given time. If some of these basic small time precautions are taken, 80% of the people can safely observe fast.
Thank you. I think we have already finished our time slot, and it was a great discussion, wonderful discussion. We learned a lot among ourselves. The endemic of the webinar endemic has really a boon to the medical fraternity, because we can share our knowledge with our colleagues. We can pass our time during this webinar endemic. Thanks to all of you. Wonderful.
Thank you, sir. Thank you.
Thank
Thank
you.
you.
Over to the organizers. Anything to say?
Thank you, sir. It was very nice to talk with all of you. Thank you very much.